Good evening, everyone. I am Dr. Vikas Reddy, working as a consultant interventional cardiologist at Omega Hospital, Scotch. So today topic of discussion is mainly on the most important aspect which every citizen of India should know, that is the myocardial infarction. So nowadays, because of growing obesity and changing lifestyle, and we are facing a lot of sudden heart attacks. In medical terminology, heart attack, we call it as a myocardial infarction. So what is myocardial infarction and how to diagnose the symptoms and how to identify the signs, I'm going to tell you in this seminar. So first of all, what is myocardial infarction? It is synonymous with the coronary occlusion or the heart attack. Whenever there is a reduction in the blood supply to the heart, obviously the heart muscle will undergo necrosis. That is called the myocardial infarction. And what is the cause of the myocardial infarction? So usually heart has three arteries supplying the cardiac muscle. So two on the left side and one on the right side. Whenever there is a blood clot within the arteries supplying the heart, obviously there will be a reduction of the blood supply causing the infarction. So in simple terminology, myocardial infarction occurs whenever there are blood clots in the arteries supplying the heart. So what is the cause of this blood clot? So the most common cause is nothing but the plaque rupture. So first of all, what is a plaque? Every individual, once we cross 20 years of age, our coronary arteries they keep on accumulating cholesterols. Initially, we call them as a fatty streaks. So as we age, the fatty streaks keep on depositing cholesterol, and these ultimate cholesterol will develop into the plaque. That is, we call it as a atherosclerosis. So whenever there is atherosclerosis, which is nothing but it's a continuous process, and because of hypertension, because of diabetes, and because of smoking, these are the common risk factors which can cause this plaque rupture. So whenever there is a plaque rupture occurs, it attracts the platelets as well as the red blood cells, forming the clot. This is a simple pathological process behind the myocardial infarction. So once there is a plaque rupture, thrombus forms, and this thrombus reduces the blood supply to the cardiac muscle, which causes the simple heart attacks. So there is a spectrum called the ACS, that is nothing but the acute coronary syndrome. This acute coronary syndrome includes three important subsets. One is the unstable angina, second is the non-ST segment elevated myocardial infarction, and last and most important thing is the ST segment elevated myocardial infarction. I'm going to discuss about each of this topic in the subsequent slides. So as I mentioned, this is a pictorial representation which I have mentioned just now. So this is the heart. The red color is nothing but the arteries supplying the heart. Usually there are three arteries, one on right side and two on the left side. These we call it as a coronary arteries. So when you dissect or when you zoom the artery, so within the artery normally there should be a blood flow without any of these fatty streaks. But because of risk factors which I mentioned earlier like smoking, hypertension, diabetes, there is accumulation of cholesterol causing the plaque. So as long as the plaque is stable and as long as the plaque doesn't block more than 50% of the artery, the patient doesn't have any symptoms. But once the plaque crosses like more than 50%, and once there is a plaque rupture, there is a blood clot which reduces the blood supply to the heart muscle, which causes the myocardial infarction. So going into each subset, the first subset is the unstable angina, which is very most common. So unstable angina occurs whenever there is a reduction of the blood flow to the heart. Similar mechanism, but the only difference is that the artery is not completely occluded. So the artery usually has more than 50 or 70% of the blocks, which is the cause of the patient's symptoms. So how to diagnose unstable angina? I'll tell you in the subsequent slides. And once any patient or any person, if they neglect the unstable angina, that is a chest pain, eventually they are going to land in a heart attack. That is a myocardial infarction. So according to the statistics, you know that 1/5 of the world population, especially cardiovascular deaths, occur in India. Of this, 24.8% of deaths occur in India mainly because of cardiovascular diseases. And if you take the prevalence, almost like 54.5 million cases in India are suffering from the cardiovascular disease. So all these cardiovascular disease patients, they are at risk of developing the heart attack, and approximately 1/4 of them will have the MI each year. So the most important, I say the paradigm or the notion is that time is muscle. So whenever someone develops the heart attack, he should reach the hospital and he should get the treatment as soon as possible without any delay so that his heart muscle is preserved. If there is a delay, even if we intervene, like even if you do like angiogram as well as the stenting, the patient won't benefit. So time is muscle. Please keep in mind, whenever someone has the chest pain, get an ECG. If it shows myocardial infarction, reach the nearest hospital as soon as possible. So what are the causes of myocardial infarction? So these are the various mechanisms which cause the reduction of the blood supply to the heart. The most common is the vasospasm. That is, whenever there is a constriction of the coronary arteries, there is a reduction of the blood supply, which ultimately causes the heart attack. So there are certain drugs like nowadays, because there are a lot of cocaine addicts and a lot of like people are taking the drugs like marijuana and all. So all then cause this vasoconstriction, which causes the heart attack, and there is a sudden death of these patients. And the second mechanism is the decrease in blood supply, which is mainly because of hypotension. Whenever someone suffers from the low BP for a prolonged period, very low hemoglobin levels, because hemoglobin is nothing but the oxygen carrying agent in the body. If there is a low hemoglobin, ultimately the oxygen supply to the heart is reduced, which causes the myocardial infarction. And another mechanism is, rather than the reduction in the supply, there is increased demand. So as I mentioned, whenever there is an increase in heart rate because of various like marathon runners, athletes, football players, and whenever there is a thyrotoxicosis or ingestion of cocaine, all this cause increase in demand of oxygen. And if the body doesn't meet this demand, ultimately they succumb to the heart attacks. So now how to identify the myocardial infarction? The most common symptom which you hear nowadays is the chest pain. Not every chest pain is a heart attack, and not every heart attack will have the chest pain. So the classical chest pain will be in such a manner that usually the pain starts in the center of the chest towards the left side, and the chest pain can occur anywhere from the jaw to the umbilicus. So there is a wrong notion among many of us that heart attacks occur only whenever there's a chest pain. That's wrong. Even simple jaw pain can also be a symptom of the heart attack. And sometimes the epigastric, the stomach pain can also mimic the heart attack. So it can occur anywhere from the jaw to the umbilicus. The pain is usually persistent. It's a constricting type of pain. The pain is severe in such a manner that someone usually comes to the hospital with his hand over the chest. That is the severity of the pain. And the pain keeps on increasing in the 5 to 10 minutes. Usually, if really say because of the heart attack, the patient cannot tolerate this pain and usually they will collapse. This is the characteristic distribution of the angina. So whenever there is a chest pain, there is an associated pain in the left hand also. As mentioned this diagram, it can radiate from the shoulder to the tip of the fingers. So some people usually comes to me complaining of only pain in the left hand. That is wrong. Even the simple cervical spondylosis can also cause pain in the left hand. Whenever the chest pain is associated with the left hand heaviness or left hand tingling and numbness, that is a symptom of a myocardial infarction. And apart from the chest pain, which I just mentioned, there are other symptoms which can also be the predictors of the myocardial infarction. One such symptom is the shortness of breath. So when someone feels difficulty in breathing while climbing stairs of more than 2 or 3 flights of stairs, and if they cannot walk for more than 100 to 200 meters, then such kind of patients should visit the nearest cardiologist and they should check their cardiac status. And indigestion. This is one of the vague symptoms. Sometimes most of the people come to the hospital with stomach pain and the indigestion, with vomitings as well as loose stools and all. There's a type of myocardial infarction which I'm going to discuss. It typically presents with the stomach pain and the indigestion. So please, if indigestion is persisting, get an ECG so that at least the cardiac aspect is ruled out. And the other symptoms are the tachycardia, that is the increase in heart rate, and tachypnea, that is increase in the respiratory rate. These are also the other two symptoms of the heart attack. So what are the reason for all the symptoms? That there is something called the catecholamines in the body, which are nothing but the adrenaline as well as the noradrenaline. These sorts we call it as a stress receptors or the stress hormones. So whenever there is a pain in the heart, these hormones get released into the body, which causes perspiration, that is excess sweating, anxiety, restlessness. These are all the symptoms of the catecholamine response. Fever, there is one of the vague symptoms. Sometimes because of ongoing pain and inflammation, uh, some patients present with a fever, but fever alone is not a symptom of the myocardial infarction. The fever should be followed by the chest pain, difficulty in breathing, as well as the tachycardia. So how to prevent? So anyway, we tend to treat the patients very early nowadays. So most of the patients are surviving, but still in the remote areas, there is a lot of patients who are succumb to the heart attacks because of lack of quality care. So our main motto should be the prevention of the heart attacks rather than treating the myocardial infarction. So how to prevent it? A healthy lifestyle is very, very important. So I tend to advise all my patients that do exercise for at least 30 minutes a day. You don't go, no, 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 you don't need to go for the gyms or go for vigorous marathon runs and all. Just brisk walking for at least half an hour a day daily will keep you fit. It reduces your blood pressure as well as the cholesterol so that you may not develop the heart attacks. And diet is very important. So nowadays, India is the capital of diabetes, and somehow the Indians are genetically obese. A person who is fat doesn't mean that he's high risk of myocardial infarction, and a person who is lean doesn't mean that he's protected from the heart attack. Indians genetically we are obese in the sense, so there is a tendency for most of us to have the diabetes as well as the hypertension at 25 to 30 years of age. And that is really happening nowadays because of a lot of other work factors. So diet is very important. We need to take a diet rich in proteins and low carbohydrate diet. So better to avoid white rice as well as the maida, atta, which are rich in the carbohydrates. Take something made up of millets, fruits, vegetables, and meat. White meat is very good. That you can take chicken, poultry as well as the fish, but red meat like mutton need to be avoided. And the most important factor is the smoking, because smoking contains the nicotine, which is causes the vasoconstriction, and ultimately this can cause the myocardial infarction. So never ever do smoking, because it is one of the most common risk factor for the MI. So how to assess and diagnostic findings is, once patient presents to the hospital with a chest pain as the difficulty in breathing, we tend to investigate the patient whether this pain is mainly because of a heart attack or there are some other causes of the chest pain, which are usually manageable with the symptom tablets. So first of all, we'll take an ECG. If ECG shows the ST segment elevation, then we call it as a myocardial infarction. Such patients we need to take immediately for the cath lab without any waiting. Some patients ECG is absolutely normal, but they keep on complaining the pain. If the pain usually severe, and if those patients having the risk factors like the smoking, hypertension, diabetes, we tend to order certain tests to confirm whether the pain is really because of the heart or not. So the most important test is the troponin, which is very specific for the heart. Either troponin I or troponin T, both are same. But the only difference is that those patients who are already having the kidney disease or CKD patients, we tend to order the troponin I because it is not excreted through the kidney, whereas troponin T is excreted through the renal parameters. So the dictum is that the troponin tends to get elevated only 6 hours after the onset of the chest pain, not early, and they tend to remain for 7 to 14 days within the blood. So whenever when you go to a nearest nursing home or the doctor, if they order troponin too early, it may be negative. So better to wait for at least 3 to 6 hours before ordering this test, so that it will become positive. And the other test is the CPKMB, which is outdated test. We don't do it routinely, but CPKMB gets immediately get elevated within the 4 to 8 hours, and it returns to normal within 2 to 3 days. Nowadays, we really don't do the CPKMB test to diagnose a patient with a myocardial infarction. So going into the ECG findings, ECG is a very big topic. It's not easy for all of you to understand, but I just want to concentrate on the most important ECGs which we see in our day-to-day practice. The first is the myocardial infarction of the anterior valve. So usually ECG will have the 12 leads. Okay. So the 1, 2, 3 are called the limb leads. AVR, AVL, AVF, we call it as an augmented leads. And V1 to V6, we call it as a chest leads. In this, the V1 to V6 corresponds to the anterior wall of the heart. That is, these leads will be facing the anterior part of the heart. And 1 AVL, V5, V6 will be facing the lateral part of the heart. And 2, 3 AVF will be facing the inferior aspect of the heart. Accordingly, we named it as an anterior wall MI, inferior wall MI, and the lateral wall MI. So if you see the ECG, you can see these tall waves called, these are nothing but the STs, that is the tall T waves. There is a ST segment elevation in the V2 to V6 and also in the 1 and AVL. So this is an extensive anterior wall MI, which is very deadly. And if you intervene such patients at the right time, we can save the life of the patient. And as I mentioned here, you are seeing the elevations in the 2, 3 AVF, which are nothing but the inferior leads. So it is a inferior wall MI. At the same time, you can also see the ST segment depressions. So if you notice that lead 2, lead 3, so please look at my arrow. This, we call it as a TP segment. So any thing which is below this TP segment, we call it as a depression. If you see in the V2 and V3, these are called ST segment depressions in the V4 also. So these corresponds to the posterior aspect of the heart. So it's a infero-posterior wall myocardial infarction. So this is another most common issue which is missed by most of the even doctors also. So here you are seeing the ST segment depression, the V2, V3 and V4. So this is corresponds to the, as I mentioned, the so to understand simple, so ECG will have basic 5 component wave. This is the PR interval, the R wave, and this we call it as a ST. This is actually ST segment. Here it is elevated, so we call it ST segment elevation, and this is the TP segment baseline. So this is a simple ECG. So if everyone try to read more normal ECGs, then they can find what is abnormal. And In contrast to the ST segment elevation myocardial infarction, there's something called the non-ST segment elevated myocardial infarction, where instead of ST segment elevation, we'll have the ST segment depression. If you notice here, the you can see this depression below the baseline. So this is a case of NSTEMI. So this is a ECG which you can see diffuse ST segment depression in almost every lead, in lead 1, 2, 3, AVL, AVF, and also in the V3, V4, V5, V6. This is a typical ECG of the non-ST segment elevated myocardial infarction. And in this, only the AVR lead, sometimes V1 will have the ST segment elevation, which you are noticing here. And again, this is one of the classical features of the non-ST segment elevated myocardial infarction. And coming to the ECG of unstable angina, as I mentioned, the ECG will be absolutely normal. And most of the even doctors tend to miss the unstable angina. Whenever we find such an ECG, and if patient keeps on complaining the chest pain, we tend to order this troponin. If troponin is positive, it indicates the patient is having that heart attack. We'll take for the angiogram. If it is negative, then we can send the patients with observations with some tablets, and we tend to review after 24 hours. So this is how we diagnose the myocardial infarction based on the ECG, based on the cardiac enzymes, that is the troponin T. So once we confirm the patient is having the myocardial infarction, we need to treat the patient before shifting to the cath lab. There are certain drugs which are very important, which really saves the life of the patient. Because once the patient comes to the hospital, it takes at least 30 minutes to 1 hour for us. Even however the bigger hospital is, it takes at least 30 minutes for the patient to be shifted to the cath lab after all the financial counseling and everything. So this 30 minutes is very, very important. So during this 30 minutes, we'll give certain drugs which helps the patient to survive the critical period. The most important of this, we call it as an antiplatelets, which includes the aspirin, which is the most important antiplatelet. And we tend to give the other drug called the ticagrelor, which I didn't mention here. These two are the most important antiplatelets. And whenever the patient is having the low saturation of less than 90, we tend to give oxygen. And nitroglycerin is a drug which tend to give for the chest pain. It improves the blood supply and reduces the chest pain. Morphine we don't give nowadays because it has a lot of side effects. It delays the gastric emptying and all. So better to avoid morphine nowadays. And if the patient is in the peripheral setting where they cannot approach a hospital with a cath lab, we tend to give a drug called the thrombolytics, which are nothing but the streptokinase, alteplase, and teneliglipase. These are the drugs which really saves the life of the patient. And once we give the thrombolytics, we can shift the patient in the next 2 to 3 hours to the nearest hospital with the cath lab so that we can do the angiogram. So this is the simple aspect. I know like there's a lot of doctors in the audience who are practicing in the periphery setting where they did not have the cath lab and all. So for them to save the life of a patient, once you confirm in the ECG that the patient is having the heart attack, give that simple drugs which can save the life of the patient. This is the ticagrelor, which is the most important antiplatelet. Of this, the dose is usually 180 milligrams, and ecosprin is the 325 milligrams. This is the start doses. We call it as a loading doses for the effect of the drug to kick in. We should give these drugs. Atorvastatin is a statin with a dose of 80 mg. If you give these three drugs, 90% of the patient will be alive till he shifted to the cath lab, even though if the cath lab is delayed. And heparin, which is nothing but an anticoagulant, we can give the 4,000 units. We can give even the Clexane, the low molecular weight heparin also. But there are some contraindications. If the patient had suffered from the hemorrhagic stroke, that is the bleed inside the brain, in the last 6 months, we never give this heparin as well as this ticagrelor drugs because there's a tendency of bleeding. And instead, we give a drug called the clopidogrel 6 mg as the loading dose. Because ticagrelor is the very most important antiplatelet, which tend to increase the bleed sometimes. So better to avoid in hemorrhagic stroke patients. So as I mentioned, these are the drugs which I tend to give in a peripheral setting where we don't have the cath lab. When I go for the ORC camps and all, we tend to give these drugs. And of this, I don't want to bombard you with the knowledge of all these doses of the drugs. Just remember the name of the drug, that is a teneliglipase, which is easily available nowadays. And it's very easy to give. You don't need any saline or infusions. You just load the drug. Depending on the weight of the patient, you give the just bolus as the start dose of the drug. So the normal dose we tend to give is the 40 milligrams because most of us are 70 to 79 of age. And again, this drug is very, very weight specific. And but it is very costly. It costs around 50 to 60,000. If someone who is really poor, who cannot afford, we can give a drug called the streptokinase, which is just like 2 or 3,000. And this streptokinase, we need to give over a period of 30 minutes to 1 hour as a slow infusion in a dose of 1.5 million units. And sometimes one of the disadvantage of the streptokinase is that there's a lot of allergic reactions to the streptokinase. The patient can go into hypotension. Sometimes we need to stop the drug. These are all some of the factors which you should keep in mind when you're giving the streptokinase. And there are some contraindications to these thrombolytic agents. The absolute contraindication is that any previous hemorrhagic stroke, any known structural cerebral vascular neoplasm, or any AV malformation. If the patient had an ischemic stroke in the last 3 months, if they suspect, and menstruation is not a contraindication, you can give safely. If there is a significant head trauma or the facial trauma within 3 months, these are the absolute contraindications where we don't give these thrombolytic agents. And in such cases, better to give the loading tablets and shift the patient to the nearest hospital with the cath lab. And there are some relative contraindications in the sense we can give the thrombolytic agents after blood pressure. Then we tend to give these thrombolytic agents. If the patient had the stroke of more than 3 months, if there is a prolonged CPR like more than 10 minutes, recent bleeding, and if there is pregnancy, active peptic ulcer, these are not the contraindications, but everyone should keep in mind, and we should tell the patients about what are the advantages and what are the disadvantages of the drug before giving the drug. Because some patients may bleed inside the brain if you give the drug, again the attendants may question us. So always explain the side effects of the drug before giving to the patient. So till now I discussed what is myocardial infarction and how to treat at a basic periphery level, how to identify the ECG, and what are the tests we need to do. There is something called the cardiogenic shock, which is one of the most critical subset of the myocardial infarction, in the meaning that the patient usually presents to the hospital without any blood pressure. We call it as a hypotension shock. These patients sometimes will also be pulseless. We cannot feel any pulse. So the definition of the cardiogenic shock is that if the BP is less than 90 millimeters of mercury for more than 30 minutes, or if we require certain injections to maintain the BP of more than 90 millimeters of mercury, we call them as vasopressors, then we say the patient is in cardiogenic shock. And there is evidence of the end organ damage. If the urine output is less than 30 ml per hour in the last 2 to 3 hours, if the cardiac index is less than 2.2, and the wedge pressure is more than 50 millimeters of mercury, these are the things which we call it as a cardiogenic shock. So, like how to treat the patient in cardiac shock? So we tend to give certain drugs which usually saves the life of the patient. The most important of this is the noradrenaline, which is a alpha as well as a beta agonist, but it acts on the beta 1 receptors of the heart, and it helps to improve the heart rate as well as the inotropy, that is the pumping effect of the heart. Inotropy is nothing but the pumping of the heart. Chronotropy is nothing but the increase in heart rate. Dromotropy is nothing but the relaxation. So if there is a one drug which usually promotes all these three and improves the cardiac function, that is the noradrenaline. So immediately we tend to start the noradrenaline so that the patient BP will be maintained at least above 90 millimeters of mercury. And other drug is epinephrine, which we tend to give nowadays for the cardiac shock also. And there are other drugs like dopamine, dobutamine, which we tend to give only in certain aspects whenever there is a renal failure. If the patient requires a renal perfusion, we tend to give the low dose of dopamine. And dobutamine should be given only if it's an inodilator, so it has one of the side effect of low BP. So only if the BP is more than 90 millimeters of mercury, we should give this dobutamine. And levosmenon is one of the most important drug which we tend to prescribe then and there. The advantage of levosmenon is that even the BP is low, we can give this drug because it acts on the calcium receptors and increases the cardiac function. So whenever we see a patient with the cardiogenic shock and such patient having the myocardial infarction, we tend to do the shift the patient to the cath lab. In cath lab, before we tend to do the stenting, we need to support the patient because all the contrast, all the whatever the balloons, wires we pass, everything is a great insult to the heart, so that the patient may not receive the proper blood supply. There are certain devices called the mechanical circulatory devices, which helps the heart to keep on pumping while we do the procedures. So I'm going to deal with the mechanical circulatory support just in the brief because these are very complex and each one requires a separate topic. So I'm going to mention the names and how they look for your just knowledge. The first one is the intra-aortic balloon pump, which is a very basic one. We call it as a poor man's heart because IBP helps to maintain only 500 ml of the cardiac output during the procedure. And there is something called the impella, which is 2.5, and impella 3.5, or impella CP. This is the impella is nothing but it is a rotatory motor which takes over the function of the heart, and instead of the heart, it pumps the blood to the rest of the body so that rest of all organs will be maintained while we do the procedures. The only thing is that impella is very, very costly. It costs somewhere like 20 to 25 lakhs. So very few people in India can afford the impella. And there's something called the tandem heart as well as ECMO, which are very invasive procedures which we tend to do with the help of the surgeons. So these are the pictorial diagrams. The first one is the intra-aortic balloon pump, which we generally tend to pass from the femoral artery, and we tend to inflate the balloon from the descending aorta to the arch of aorta. It keeps on inflating and deflating so that the some of the blood is pumped back to the heart and coronary so that the heart will receive the blood supply. And remember, it gives only the extra 500 ml of the cardiac output, not much. Whereas Impella, which is, as I mentioned, it's one of the most advantage of this Impella is that it almost gives 3.5 liters of cardiac output. That is how the normally heart pumps. That is 3.5 to 5 liters is the normal cardiac output. It almost takes over the cardiac function so that the patient will be alive during the procedure. And really, if the patient is affordable, Impella really works wonders. Then other most important aspect is the tandem heart as well as ECMO, which we tend to pass from the femoral artery and femoral vein. And ECMO is something which is completely out of the body. There is a big circuit which draws the deoxygenated blood from the body, and there is something called the oxygenator. It does the function of the lungs also. That is, you know, the lungs usually keeps on exchanging oxygen and carbon dioxide. ECMO has something called the oxygen filter, which usually gives oxygen to the deoxygenated blood. Again, it pumps through the femoral artery. So it almost takes the function of the heart and the lung. You know, in the COVID, I mean, you may have had a lot of people have this ECMO, and really ECMO is also a lifesaver, but it's comparatively cheaper when compared to the Impella. But disadvantage of ECMO is it's very invasive, and there's a lot of vascular complications which we need to face after the procedure. There's something called the tandem heart. Again, this we tend to keep with the help of the surgeons, which is very invasive and costly. There's something called the Impella RP. This is for the right heart. That is, whenever there is right ventricular dysfunction instead of the left ventricular dysfunction, we tend to give something called the Impella RP. This Impella RP which help to maintain the cardiac output. Again, this is how the IABP console looks. There is a helium gas in the cylinder back of this machine. Through that, it keeps on inflating and deflating the balloon in the aorta so that the heart pumping will be maintained. And this is how Impella CP looks. This is how we do angiograms. Here, there is a tight left main stenosis. These patients will not survive if you do just angiogram and the PTCA without the Impella. So Impella takes over the heart function so that the patient will be alive, so that the rest of the organs will be preserved during the procedure. And this is how the tandem heart looks like. There is a motor which is tied to the thigh, and it keeps on. There's a rotatory motor inside. It draws the blood and oxygen and returns to the heart. Again, it is very invasive and very costly. And ECMO is very common. There are two types of ECMO called veno-venal and veno-arterial ECMO. For cardiogenic shock, we tend to use a veno-arterial ECMO. And veno-venous ECMO is mainly for the COVID cases and where the lung is primarily affected. If the heart is good, then we go for the veno-venous ECMO. So veno-arterial ECMO, again, as I mentioned, there's something called the pump as well as the oxygenator. It draws the deoxygenated blood from the femoral vein into the oxygenator. Again, with the help of the pump, it pumps to the heart so that the kidneys, brain, and rest of the organ will receive the blood supply, even though the heart is not functioning. In ECMO, the heart will be standstill and it would pump sometimes if still the body is able to survive with the help of the ECMO. So once we have done with all the aspects, that is, once we can deal with the MI patient and those with cardiac shock with the help of these mechanical circulatory devices, we'll shift the patient to the cath lab where we'll do an angiogram. Angiogram will help us to know which artery is occluded and what percentage of artery is occluded. And with the help of these balloons as well as the stents, we tend to open the artery. That's how we do a procedure called the PCI, that is a percutaneous coronary intervention, where we keep the stenting. So it is maybe indicated for unstable angina and also for the NSTEMI patients, because not only myocardial infarction occurs because of ST segment elevator, even ECG can be absolutely normal, but troponin can be positive. Such patients should also undergo angiogram as soon as possible. And if they found like more than 70% of lesion inside the arteries, they should get this stent done so that they can prevent from the future heart attacks. So that's it. Thank you. And I hope you understand all this. And this is a basic knowledge like how to diagnose, how to treat at the basic level. I'm not going to the depth of the myocardial infarction. There's a lot of things to discuss further. I think if you have any doubts, please feel free to ask
Yes,
me.
sir.
I would be
They
happy.
have posted the questions in the chat box, which I'll be reading for you. So we can take up the questions one
Yeah.
by one. There's a question from Neha. What are the latest advancements in early diagnosis of myocardial infarction?
So to be precise, there are no latest advances. There's something called the high sensitive troponin I. As I mentioned, the troponin I, we need to wait for at least like 4 to 6 hours for the test to become positive. There's something called the high sensitive troponin, which we can able to detect the myocardial infarction within the 1 hour. But troponins are only for those people where the ECG is normal and ECG doesn't show any ST segment elevations or depressions, but still the patient have the heart attack. We tend to organize stress. There is an advancement which we are nowadays using routinely high sensitive troponin. They tend to become positive in the 1 to 3 hours, so that we can diagnose the patient earlier.
This question is, yes, sir. In what cases can ECG findings be misleading in MI diagnosis?
It's a good question, really. There's a lot of factors where ECG can have the changes of MIs. There's something called the myocarditis. So even simple COVID infections or any viral infection can affect the heart, and there's something called the myocarditis. That is inflammation of the cardiac muscle. If there is inflammation of cardiac muscle, they can also show the ST segment elevations and depressions. Again, as I mentioned, entire clinical scenario is important. ECG, looking at the ECG, we cannot diagnose. We need to see the patient. We need to ask if there is a chest pain. If we need to ask whether he has suffered from previous any, like in the last 1 week, he had any fever or the recent viral infections. And we need to do a test called the 2D also, which I forgot to mention. The 2D is something which predicts the pumping of the heart. If the pumping is low, if the patient had a previous viral infection, then we can confirm that's a case of viral myocarditis. And most of these patients tend to respond with the steroids. We don't do angiograms for such kind of patients. We tend to treat the viral infection as well as steroids so that the ECG changes will disappear.
So this is from Kirti. What is the current recommended door to balloon time for PCI in STEMI patients?
So there are a lot of recommendations, but my personal recommendation is there is no limit as soon as possible. That is the best dictum. So usually the dictum is 30 to 60. It depends on the hospital. If the patient is in the like a type 3 cities like Hyderabad and corporate culture and cities, they need to reach the hospital in the 30 minutes. If it's someone from the periphery, which takes at least like 1 hour to travel, the maximum door to balloon time should be like 90 minutes. It can be relaxed up to 120 minutes. That is a 2 hour. We should not exceed like more than 2 hours. So the ideal time is 90 minutes.
So this question is from Nitish. What are the pre-diagnostic tests a person can go for screening and in case of diabetic patients also?
Yeah. So again, it's a good question. See, nowadays, as I mentioned, Indians are we are genetically obese, right? So starting from everyone who crosses 20 years of age should get that this test at least once in a lifetime. Lipoprotein A is nothing but it's one of the marker which is the predictor of the heart attacks in the future. If lipoprotein A is normal, then one can reassure that provided in the future, if he or she cannot develop the diabetes and the hypertension, they are safe. Again, once if lipoprotein A is normal, every year once your age crosses like 30 years of age, annual health checkup is very important. Of this, fasting lipid profile, HbA1c, ECG, 2D co. These four are very these are basic minimum requirements. So we can able to pick up the diabetes from the HbA1c earlier. We can able to modify the lipids so that you can modify your lifestyle also. So these are a simple basic test which everyone who crosses 30 years of age should undergo.
Okay, sir. Great. There's a question from Sudhir. I can see some people are going for Unani, even their drop I, drop T positive. Does it really work? Drop I think so.
No, no, no. See, there in medicine there should be evidence for everything. I mean, we are practicing allopathy, so we tend to support because we have evidence. Everything we do, we can see the result before our eyes. Unani, Ayurvedic, I don't believe whether there really there is no data, there is no evidence. A lot of patients come to me after receiving Unani that blocks have increased. Some patient almost died, and some patients come with a liver failure, renal failure because of the side effects of the Ayurvedic and the Unani drugs. I don't know whether there's a real treatment, but there is no evidence for Unani and Ayurvedic in terms of myocardial infarction.
Okay, sir. This question from Dr. Mansoor Ali Sultan Khan. What are the causes of SCD in young and athletic fitness? How to avoid such deaths? How to approach such cases with regards to its diagnosis, investigations, or RX?
So yeah, that's a good question actually. The sudden cardiac death, there is a lot of factors. See, nowadays there is a lot of, husbands going in the media that so and so patient died from sudden cardiac arrest and all. Usually, you should know the background of the patient who has suffered from the sudden cardiac death. He may have smoking history, or she may have some family history of early onset of myocardial infarction. So there's something called the genetics. That is, genetics play an important role in the family history. If our grandparents, our father, even their grandparents suffer from the heart attack, that is, if you find MI in every generation of your family, by default you are at a high risk of developing the heart attacks. There's something called the genetic anticipation. If suppose your grandfather suffered from heart attack at 60 years of age, your father at 50 years of age, there's something called the genetic anticipation where you may have the heart attack at 25 to 40 years of age. Again, by appropriate blood tests like lipoprotein A and the lipid profile, which I mentioned, you can prevent the heart attacks. And even something called the genetic studies nowadays we are doing routinely for something like HCM, that is hypertrophic cardiomyopathy patients, where most of these patients will die suddenly at 40 to 45 years of age. these patients, if they do simple tests called the ECG as well as the 2D echo, we can identify such patients and we can go for the genetic testing. There is something called the genetic therapy also, which we tend to alter the genes so that we can save the life of the patients.
So, it's a good explanation. Antiplatelet therapy, DAPT play post MI, and how long it is recommended?
So DAPT is a mandatory. It depends on the again age of the patient and depends on the bleeding risk of the patient. For a normal patient who is young, like less than 60 years of age, we tend to give DAPT for at least 1 year after the myocardial infarction. Later, we shift to the senior smoke who are having uncontrolled diabetes even after the myocardial infarction. For those patients, we tend to continue the DAPT provided those patients should be of low bleeding risk category. So for those patients, we can continue DAPT indefinitely. But keep in mind, they should keep on visiting their cardiologist once in 3 months. So and they should able to explain any bleeding manifestations to the cardiologist.
I think that's it, sir,
Okay.
from the participants. And I really thank you for your patience. Now I hand over to Sai Priya to give a end note
Yeah, sure.
and word about you the session. Thank you, sir.
Thank you. Thank you, Priya.
Good evening, everyone. Thank you so much for joining us today. And a special thank you to Vikas Reddy sir for his insightful session. Before we close, I would want to introduce you to the platform that made today's session possible. Is my screen visible?
Yeah, now it is visible.
So, the MedWorld Expo is a unified digital platform built to support your career, learning, and professional connection. It's an all in one place. So here's how you can benefit from a MedWorld Expo. Explore products here, and it also helps in great career advancement. So MedWorld Expo is more than just a platform, it's your partner in growth. We look forward to staying connected with you. Thank you.